I guess I am the token obstetrician gynecologist in the crowd, and now I know what Art Fleischer always felt when we invited him to an OB GYN course to lecture. You also will see that ideas that Dr. Ben Asraf put forward in the volume imaging will be probably a little more applicable in GYN as a volume scan, let the patient go. Since, once again, I have never seen a woman doing barium enema to take souvenir pictures home, but they definitely will want to take pictures home of their baby. So we'll see how that works out, and I will observe that in the future. I will talk about the applications of three-dimensional ultrasound in gynecology. And when I look at the reviews in the literature, they are mostly from Germany, Austria, France, some lately in the United States. Very few there are very few compared to the OB articles, about 1 to 10. The majority of the GYN 3Ds are show and tell or cases. There are very few real data on very few patients, and lately rendering applications and power Doppler uses were published. Let me show you a little bit what the tools are, and they are very, very similar to those used in three-dimensional ultrasound in obstetrics, but also a little bit different. First of all, the multiplanar navigation and scrolling. We have the famous thick-slice rendering, which I will talk about pretty many times. 3D angiography, the inversion that Beryl talked about. We have several sculpting tools available which may become important in GYN 3D. Tomographic ultrasound imaging, which once again will turn around probably the field even in the gynecologic applications, and other company owned laptop or station or softwares that are used. So let's get into particulars. First of all, the orthogonal planes or multiplanar navigation or multiplanar display or scrolling, call it as you want. Basically, it displays the orthogonal projections at right angles, and I will go very fast because these were explained. I also will have much less time to go through this, so that helps me. And the user can scroll, navigate in a continuous fashion, and the important thing here is that any plane that can be generated. We also can do this niche mode and go back and forth with every plane, up and down, right to left, and so forth. Then, of course, to use the marker dot, which I'm moving right here in order to see a saline infusion sonohysterography and point out the different polyps in order to help the practicing obstetrician gynecologists to go right to the place when they do their hysteroscopic resections. The thick-slice is a very important display modality, and that is to really take several two-dimensional successive planes, compress them or collapse them, so to say, in one single plane, as you see it here in the rendering box. And you can see that the difference between the box A and box C, where even in the not in the secretory phase, in the follicular phase, hard to see the boundaries of the endometrium. You can see them pretty beautifully in the render place if you collapse several successive planes into one, and that's the thick-slice display. Power Doppler angiography is, starts to become a pretty important tool. And what is it indeed? It is a special imaging display modality that enables selective showing of blood flow containing vessels after a 3D acquisition was done. And then you switch the power or the Doppler feature to image the desired vessels as you can see it in the background. You display it in the orthogonal planes, turn on the render mode, strip the volume of the grayscale data, leave only the vascular information, and then the blood vessels are displayed. The desired volume then is cut out by using, in this case, the General Electric generated virtual organ computer-aided analysis, or it's also called the vocal mode. The organ is cut out, as you can see it here in the background again. The power Doppler signal is semi-quantified. The volume is given, as you can see it here in the lower part. This is a pretty interesting research tool that will be probably important in the future. Now, how do you cut out this? You move one of the images that you have, one of the orthogonal images, at degrees from 9 to 30 degrees. The smaller the rotation angle, the smoother the volume will be displayed, and the more accurate data of the surface and the volume will be generated. In this case, I use the 9-degree rotational angle to obtain this ovary, for instance. Then you can display it in the glass body, and as you see it here, or the angiographic display, and of course, use a little gimmick also, you can rotate them and look at them from different angles. The same algorithm can be applied to any blood vessel containing organ. The inversion mode was already mentioned, and that is obtained by practically rendering the black areas into white, and the words are in behind, but that's not important because Barry talked about it, and I will show you many examples of that also. And then some of the sculpting tools, which become important in order to render the organ or part of the organ into in the way that is important in diagnostic. These are the scalpels and the razors. For instance, in the two-dimensional picture, I was not sure whether this has any of the markers of potential malignancy. And when it was rendered, yes, there are some papillae here which are important in order to suspect malignancy, but I was not sure whether there are other papillae in other parts also. So when you take the cutting tool and cut off part of that ovary and then move it around and look at them from the inside, you will see that even this one has pretty small but multiple papillary formations that make this ovary pretty suspect of a malignancy. So that can be done very easily the moment you move around the volume. The tomographic image display, as it was sold, is important, and let me just show you and go to a volume that I have up here and show you a little bit how that's done. This is an actual volume, and saline was put in to see whether there are any polyps inside. So first of all, I like to see them in a little different color, but you can do it whichever way you want. Then you go back and you can display it in the tomographic fashion. And this one would be the ones displaying the sagittal image of the uterus and the fluids, and you can change the distance between the slices. And once again, I'm not here to really say that anything you do I can do better, because you do this for a long time already with CT and MRI, and we learned from really these imaging modalities, but it became important for us to do, and it's so elegant and simple to do it. You can then change it and look at it in the coronal, in the horizontal view, let me say. You can enlarge them, you can move them around at will, and once again, then I will also show you, if I'm already here, go back to the sectional planes, do the rendering, try to fit this into the area of interest, go down to the render mode, invert it, put the surface rendering, do the gradient light, and then try to make it appear, go back to display it in one plane, move it around a little bit, turn it, and you can see here the two depressions of the polyp, the areas there. You can cut it out if you really want to, accept it, and cut out parts of it. And once again, excellent teaching tool in these places. So let me go back now to the actual lecture and show you the other features that we have. And we have, of course, the laptop workstations, QLab of Philips, 3D View of GE, SonoView Pro, Madison, 3D volume viewers of Siemens. The volumes containing 3D angiography, for instance, can be manipulated using the laptop software version of the program. Let me give you a little clinical examples. Clinical examples, of course, I have to start with the uterus because this is probably the place that it mostly helps. And I sheepishly enough, I will say that anything that the MRI can do in the uterus, we can do better. So you can see that you can ascertain normalcy, uterine malformations, uterine cavity, as far as polyps, fibroids, even the cervix. Now, there are several ways to image the uterus. First of all, you can examine it in the follicular phase. Not too much you will gain about it, only maybe the endometrial thickness that has to be examined in the follicular phase in a patient in the reproductive period. Then you can do it in the secretory phase, but in the secretory phase, if you don't want to inject it with saline, you can use the 3D thick slice as I showed you before. And then, of course, the saline infusion. Now, here is a saline infusion that I'm manipulating with the Philips software. I'm not very good at it. You will see it very clearly in a moment. I want to produce the thick slice, so I'm narrowing the slices as you see right there. And then here the rendering is there upside down. Then I'm moving it, hop, not good, so in the other direction, right here. And then I'm magnifying it a little. I'm now clicking it for the whole screen to appear, and now you will see that it is really pretty thick. So that's the thick slice. The scanning the uterus, the most important feature of 3D is that we can now really see the coronal section of the uterus, which you only see when you have an atrophic uterus, which is in an axial position. And here is what we really need to see every time. Saline infusion of the normal uterus displayed once again in the thick slice, normal fundal contours, normal cavity contours. You can do the inversion displayed in the cast. Our referring physicians love this. They can see that the uterine cavity is impeccable, squeaky clean. Nothing has to happen there. Uterine malformations is important because reproductive performance is hinged upon the normalcy of the uterus. Now, you can do a hysterosalpingography or laparoscopy, but lately 2 and 3D ultrasound became the relatively simple, effective, and rather inexpensive diagnostic modalities to allow fusion. I do not know even up to today why the cervix was so dilated in this case, and there no pressure was put there, and you see even the indentation of the glands of the cervix in this case. Bicornuate uterus, the different ways, just the thick slice in these two pictures, or the saline infusion in that one. A bicornuate uterus, again, the fundal contours, the heart-shaped uterus very clearly shown earlier, and once again, the tomographic displays of the same. You can see it clearly here in the middle section, and which you can then alter as you want. A septate uterus, in this case, a complete septate uterus, which was once again shown before, clearly obtained exactly in 3 minutes, just playing around with the volume. Here is another incomplete septate uterus, and displayed in the inversion mode. The 6 slice, once again, extremely important because you do not have to manipulate the uterus putting in saline. A didelphic uterus with a saline infusion, clearly showing the diagnosis in these cases. Complex anomalies. Now, complex anomalies also, the 3-dimensional ultrasound really helps. In this case, I'm not sure whether you can make heads and tail out of this one, but if I, after looking at it many times, saw that this young patient had a didelphic uterus with double vagina, and the transverse septum in the left vagina causing the blood to stagnate there and flow back into the cavity, while the other uterus was clearly had connection and the menstrual blood came to the surface. Looking at IUDs very clearly, seeing which kind of IUDs we have. You can see here several. Make the correct diagnosis of interstitial ectopic pregnancy, where 2D may hint that you have a little myometrium around here, but the 6 slice cannot make any mistake because it's clearly showing that the lack of connection between the decidua and the trophoblast in the ectopic presentation. And the same with cervical pregnancies, unequivocally making the diagnosis. Localizing a structure in the pelvis, you can see here the T shape of the bladder and the urethra. This patient had a molar pregnancy and suddenly had a little bump on the one side of the urethra that she felt with the fingers. Our gynecologist wanted to stick in a needle in order to take a biopsy. I did this 3D picture and saved her from a pretty intensive bleeding if that would have been put in. Now, the endometrial cavity, I've shown you many pictures already. Several are shown here. You can also see where the fibroids are located, how they imprint on the uterine cavity. Once again, was shown before. This is important, whether to go in and take it out using a hysteroscopic surgical method or do it through a myomectomy in an open fashion. And once again, all the doctors come up and look at these and then plan their management of the case. Endometrial polyp, I will not bore you with that anymore. We can also take a look at the vascularization of it, and mind you, the vascularization is important because the more vessels go into a polyp, the more they are suspicious of malignancy, and in this case you can determine the amount of flow that is in that area. Here is a black and white saline infusion of an endometrial cancer. Definitely the vascularization is important. Here is only the display of the vessels. That's the angiography that I was talking about. For a long time, I did not believe that the tube can be seen well, but if you look at this, you really will put in the differential diagnosis suspected ovarian cyst, but when you move it around a little bit, you will see the incomplete septae that are there. And here, again, the differential diagnosis on ovarian cyst is valid, but when you do the rendering and then the inversion, you will pretty soon see what the nature of this is, and Beryl showed you a case of this, even though it was not obstetrics, Beryl, that was GYN. And then you move it around a little bit, and you see very soon, that's the sculpting tools. You cut off whatever you don't, you clearly see that doesn't belong to it. The colorization is different. You cut off that one too, and you already start to see what I mean. This will be a hydrosalpinx. And how long did I work on this? Definitely a very short time. So here is the hydrosalpinx displayed very nicely, and indeed pathological correlation, you can see that that's how it looks. Here is another hydrosalpinx in an acute case with thick walls, very clearly showing the connections between them. Now, ultrasound and the ovary. For many years, again, I doubted that 3D will give anything at the ovaries. But we learned a lot from the pathologist. And what the pathologist does, takes an ovary, puts it on the cutting board, cuts it in two, and then turns it and looks at the surface. That's what you can do with 3D also, very simply. The last issue I want to raise is the issue of the papilla, which are the most sensitive predictors of malignancy in the ovary. And if you have that in an ovary, I think that you have to turn on the color Doppler with a very low pulse repetition frequency to try to rule in or rule out a vessel in the papilla. And 3D definitely helps you in this case. And once again, even though you will have a lot of questions about the role of Doppler lately, because there is poor reproducibility, lack of expertise, lack of equipment, variability in looking the results, you can then do angiography. And I showed you already what is done, and that was done before. I will not go back. However, and I'm not sure whether, yes, this was the slide that I was trying to get. You can determine the vascularization index, which is an absolute number. The rest, the flow index and the vascularization flow index, they are relative numbers on a scale from 1 to 100. And we looked at certain structures, and I did not show you all the structures. That's my last slide indeed, and look at the vascularization index. If you look at the ovary in the follicular phase, a certain number will be obtained. We still have to digest the importance of that number clinically. In the secretory phase, when there is more blood supply to the ovary, you can see that the vascularization increases. If you only cut out the corpus luteum, there is tremendous amount of vascularization, very similar to an ovarian cancer. That's why we always want to scan the patients in the follicular phase of the cycle in the patients who still menstruate, not to get in trouble with, labeling that patient of rule out malignancy, which definitely they don't need. And I will talk about this around 4 o'clock. PCO, hyperstimulated ovary, relatively large amount of blood vessels. And here you can see a benign cystadenoma and the tumor of low malignant potential. So the advantages of 3D ultrasound in GYN is that patient examining time is short, the volumes can be permanently stored, no degradation with time. The volumes are accessible for review in all 3 planes. They can be mailed to an expert. It's a good teaching and training tool, and the displays are interchangeable. There are very few GYN outcome studies at this time. In an increasing number of cases, 3D ultrasound is the simplest, the most effective tool to evaluate pathology. 3D angiography is a promising tool. And in the near future, we will be able to witness the introduction of several computer-aided software methods to analyze the ultrasound volumes.